Welcome to the Dental Implant Practices podcast, where each episode will explore how to integrate dental implants into your practice and into bone, with your host, Dr. Philip Gordon.
Hey guys, thanks for being listeners of the show. Go to dentalimplantpractices.com and find all of our resources. Also find us on Facebook, Dental Implant Practices page on Facebook, and go to iTunes and leave me a review on iTunes so we can help spread the message. Thanks. Welcome back to another episode of the Dental Implant Practices podcast. Today it's a huge honor for me to introduce Dr. Amos Yahav. Dr. Amos, thank you for being on the show today.
Thank you for having me on your show.
Now, for those of my listeners who don't know you, you are a clinician, a dentist, who developed the product and the company from the Augma biomaterials, which is a medical device and bone grafting company. So thank you for being on the show. And why don't you tell me a little bit about yourself, your kind of background, where you live, where you were raised, and some of your educational background.
Actually, I'm from Israel. I live in a very nice village, which is called Katir in Israel. Probably most of you are not familiar with this name because it's a small and nice village. I am a practitioner for more than 24 years. My practice was devoted for implant dentistry and augmentation procedures. That's what I did most of my day in my clinic. I graduated Davila University in Romania. And later on, I came to practice here in Israel since 1993. That's about it.
Great. So you spend a lot of your time in clinical practice, and then you did research and developed a couple products, which then later turned into the development of the Augma Biomaterials company. So you've got two products that you sell, Bond Apatite and 3D Bond. So why don't you tell people a little bit about the development of these products? How did you come to develop these products? What was the inspiration that kind of drove that innovation?
Actually, as a young clinician, when I started to perform augmentation procedure, it looks to me quite cumbersome to do. You know, you need to work with the granules to try to stabilize them in place, to work with the membrane, to trim the membrane, to cover perfectly the soft tissue. So I thought that it cannot continue in that way. We must find something that will do it much easier and much friendly to the clinician. As well, we know that most of the product that we use today actually does not transform into the patient's own bone. They are integrated with the bone, so the quality and the quantity of the vital bone in the grafted side is minimal. So my inspiration was to find something that will do it differently. So I thought that the thing that might do it is finding some kind of cement, because cement since 1982 changed all of the orthopedic field. It changed all of the construction field as well, because it gives you another possibility. So I said, let's find something that can do it as well in the dental field. I went into the literature and I was looking for finding what kind of cement exists in the literature. So there are two types of cement. One is calcium phosphate cement, which is used in the orthopedic field, and the other is calcium sulfate cement. So I knew that calcium phosphate cannot be suitable for us because we have a different we have a different specification for our needs. So calcium sulfate actually is the most ancient material which exists in the literature. It exists more than 120 years. But what amazed me, that this is the only material that is backed up by thousands of articles that most of them says that it has identical outcome as autogenous bone graft, which is our gold standard. But what's surprising me, that it's not so popular. So I asked myself, what prevents this kind of material to be popular? So I saw that it has two disadvantages. One, calcium sulfate could not set in the presence of blood and saliva. Therefore, if the clinician wants to work with this, he needs to work by increments. And even so, the material didn't set. And therefore, the resorption was very quickly and unpredictable. The second disadvantage was that the material is relatively a short-term space maintainer, and there was no real indication that have been taught how to use it properly in order to have the best results. So I know that first what I need to find is a solution how to enable this material to set in this environment, which is the blood and saliva. And I didn't want to change the chemical structure. So it took me about 15 years of development in order to have the same chemical structure of calcium sulfate without with playing with these phases. Yes, because calcium sulfate actually has few phases. Calcium sulfate actually is a plaster of Paris. We all know it. We use it in the laboratory. We use it in construction. We use it also for grafting. When we take calcium sulfate from the mind, it comes as in dehydrate form, but uncrystallized, which means that it has 2 molecules of water with one molecule of calcium sulfate. Now, there is a process which is called calcination. We place it in an oven for about 150 degrees for a few hours, and then we use 1.5 molecule of water and become the plaster of Paris that we know. It's called calcium sulfate anhydrate. Now, if we take water again and we mix it with calcium sulfate, then start a process of crystallization, and the calcium sulfate became again dehydrate in its dehydrate form, but now it's crystallized. We know that if we mix plaster of Paris with water, we leave it aside, and then about 20 minutes, 25 minutes, it gets hard and it's set. The problem was that if we wanted to use it in the oral environment, then the crystal get contaminated with the blood and the protein, and the material could not set and get hard. So instead that the setting will be 20 minutes, it took about 200 minutes. So probably most of the material is washed out before even crystallization from the grafted site, and the absorption was completely unpredictable. So if the clinician wanted to work in that way, he should absorb the blood in the grafted site, place a layer, wait a little bit, place another layer. So it's unfeasible for us as a clinician. We don't have this time, and we cannot absorb all of the blood in the area. So some of the company decided that they will make the setting outside in the company, in the factory, and then we grind it into particles. Now we have particles of dehydrate, which are much more stable in the presence of blood and saliva. And there are many articles which show that they are replaced simultaneously, they are degrade simultaneously with the bone formation rate, which actually shows that they do not disturb the healing phase. And the problem was that as a dehydrate granules, they are not cement. So actually, we use them as any other granules in the market. So we need to place them, we need to stabilize them, we need to place a membrane above them. So there is no benefit of cement in such dehydrate form. So what I did actually, I developed the Biphasic calcium sulfate. Biphasic calcium sulfate, actually, it's calcium sulfate, which most of it was after the setting, but still have the ability to behave like a cement. And that's what makes the difference. That took about 15 years of development.
To get the calcium sulfate to do what now?
To set. Now the calcium sulfate is much more stable, and it can set immediately, even in the presence of blood and saliva. Because some companies also tried it to add some additives and polymers. When they add additives, actually you raise the exothermic reaction of the material when it's set, and even so it does not set in the presence of blood and saliva. If you add polymers to the material, it's not calcium sulfate, it's completely something else. I was insisting not to add nothing to the chemical structure of calcium sulfate, because I want to use its virtues and its benefits exactly as it was documented along 120 years in the literature.
So your material is pure calcium sulfate, is that correct?
Exactly.
But you've just changed its manipulation properties to be able to set quickly and set in the presence of blood and saliva. Is that correct?
Exactly.
And that's so that it can stay in place, form, and create the scaffold for bone turnover and generation for either socket sites or for other bone grafting properties. Is that what we're talking about?
That's correct. That's completely correct. But one thing we need to remember: calcium sulfate, even if you use it in its dehydrate phase, which is much more stable, it's replaced simultaneously with the bone formation rate. Now, when we speak about replaced simultaneously with the bone formation rate, actually it's still a short-term space maintenance, which means that sometimes we need a longer space maintenance. For example, when we don't have enough bony wall that surrounds our defect, or when our defect is very large, or when we want to do a lateral augmentation or graft widening, a very big defect, then such kind of material by itself cannot be used. Why? Because it will resolve too fast and will not give us enough scaffolding properties until the bone will form. Therefore, in such cases, we create what we call a composite graft. We must mix it with some other slow resorbable materials that will slow the overall resorption of the graft in the area.
Okay, and is that what so you got two products. The pure calcium sulfate product is your 3D bond, is that correct?
Exactly. And this is the product which is the ultimate solution for socket grafting, because it's replaced simultaneously with the patient's own bone. You can place it in less than a minute. You finish the entire graft placement and stabilization. The graft replaced simultaneously, and in 3 months you have the patient's own bone in the area. So this is the best one that can be for such procedure. But if you will take the 3D bone and try to work with it by itself in a larger defect, probably it will resolve too fast and you would not have nothing. Therefore, we have the other product, which is the Bond Apatite.
So you've got basically two products for two different scenarios. You've got 3D bond, which is made for socket grafting and quick resorption, and you've got Bond Apatite, which is made for longer turnover, larger defect grafting, correct?
Exactly. The Bond Apatite actually is composed of 66.6% of biphasic calcium sulfate matrix and 33.3% HA particles in a controlled particle size distribution. We have small particles and bigger particles and medium size. Now, why we do this? Because and all of those are in very different shapes. We did it in order that from one point of view, we can preserve the three-dimensional space for a longer period. And from the other point of view, the small to medium-sized particles resolve in 4 to 6 months. They are not there already. The larger particles, which are less than 10% in volume, they can stay even 1 year or 2 years. If you will re-enter to a case, you will see like somebody is grinding them. You can see that even hydroxyapatite, when you give him the condition, it can resorb. That's because normally we know that hydroxyapatite is not supposed to resorb, but this is not true. It depends. If you give him the condition, it can resorb as well. Okay, so kind of walk me through some of the processes. Now that we know, they're both made off of a calcium sulfate and some hydroxyapatite crystals, we kind of understand what the chemical process of these two. You've got two products for two different reasons. As a clinician, I'm thinking, okay, walk me through the one procedure. You've got a socket grafting that you take a tooth out, you're wanting to graft that socket site. You said the 3D bond is the product for that. Walk me through what goes on after the tooth is out and you're getting ready to use this 3D bond. So after extraction, first we need to verify that there is no granulation tissue within the socket, because we need to come in direct contact with the bony wall. So if we need to correct the socket, we correct. If we don't need to correct, of course, we don't do it, because there is no need to do correctage when you don't need to do so. And then you activate the 3D bond within its syringe. Now, the 3D bond, actually, we provide the clinician as well a vial of sterile saline, and it's important to use a sterile saline that was now open, because some clinicians are used saline that has been used for few surgery. This is not right to do, because those are most of the time are contaminated. After 3 hours already, a saline bag is getting contaminated since it was open. So we provide a small vial of saline. We provide a syringe and a needle, and there is a protocol which everybody can see in the YouTube by writing down 3D bone hands-on training or something like that, and they can see exactly how we do it. So after activation of the material, we eject the needle into the driver of the Bond Apatite, and we start ejecting the liquid until we see a small droplet coming out. We withdraw with the needle, and then we expel the liquid surplus until we feel maximum resistance. Then we take the head of the driver of the 3D bone, and we eject it into the site. Now, this is very important. When you eject it into the site, the only thing that you need to do is take a dry gauze and press above for 3 seconds. Do not use any tool to try to condense the material until the bottom of the socket, as we do when we work with granules. Because if the clinician will do so, due to the expansion of the cement, the patient might feel pain after 1 or 2 days. So we leave the bottom of the socket with the blood clot. The blood clot actually is one of the best graft materials that can ever be. So the bottom of the socket is actually the blood. We eject the material from the upper part until it stops, and then we take a dry gauze and press above for 3 seconds. At this stage, we always overfill a little bit. At this stage, if we reflect the flap, we must close it for primary closure. But if we didn't reflect the flap, there is a very nice technique that we can use a collagen sponge or any kind of barrier that can stay there for at least 10 days. We must suture this collagen sponge together with the soft tissue in order that it won't move, and we give a physical barrier until the healing will take place. Now, calcium sulfate is very well known by its ability to give the proliferation of the soft tissue above it to cover the graft, even if it was exposed. The problem that if we leave it exposed without any protection, we might lose volume. Therefore, we must protect it with some collagen sponge. This collagen sponge is sutured together with the soft tissue, and we can add some 2 crisscross suturing in order to prevent its movement. What the clinician will see is that gradually in the first 2 weeks, you will see how the soft tissue is covering the area and the collagen sponge is resolved instead. And that's the most easy way to do socket grafting when you don't reflect the flap. Now, something which is very important is to understand the radiographic appearance, because here we are talking about material that is replaced into the patient's own bone. It means that in the first day, it will appear radiopaque. After 1 week, you will see radiolucency on the border. After 2 weeks, after 3 weeks, everything will disappear. All the socket will look radiolucent. A clinician which is not familiar with this phenomenon can be sure that he lost the graft, but actually this is the osteoid before calcification. Just wait until the 3 months, and then you will see the exactly trabecular form of the bone built in that area. So this is something which is very important to know. So 2 things are important to know. When you work with the cement, it must be simple. Place, press, and close. Don't use a tool to condense it into the bottom of the socket, and be familiar with the radiographic appearance.
Great. Now, can you also use this in like a posterior molar and cover it up with a non-resorbable membrane?
Yes. In a posterior molar, if you have a septum, you can use the 3D bone. If you don't have a septum and you have a huge defect, we recommend you to use the Bond Apatite. Okay? You can use as well unresorbable membrane if you want. The only thing that you need to suture together the membrane with the soft tissue that it wouldn't move. Yes? And then after about 2 weeks or 3 weeks, you can take it out. Just don't leave it there. And you will see that beneath the membrane, the soft tissue will cover the graft.
Now, can you also use the 3D bond in a sinus graft, or would you use the other material, the Bond Apatite?
The Bond Apatite. Actually, in sinus graft, I prefer not to use the 3D bond by itself because it might resolve too fast. Sometimes when we have implants that hold the membrane in place, 3D bond can do a very nice work. But still, it's risky. So I can use it in a few different ways. Or I can use it as a buffer between on the membrane. For example, sometimes when we raise the sinus membrane, sometimes we can have a microperforation, even until 3 or 4 millimeters is the maximum. So then what I can do, I just eject the 3D bond near to the membrane, take a dry gauze above it, and with a spatula, just touch it. And then suddenly you have a wonderful roof that covers all of the membrane, and it covers also the small perforation that exists there. Thereafter, you can insert into the sinus granules. Now they will not come in direct contact with the Schneiderian membrane. And when you finish, you can close the sinus windows also by another 3D bond. The advantage is that first, you block those perforations and you don't have a direct contact between your granules and the perforation. Second, you enrich the area with calcium ion. I think here is the place to explain exactly how does calcium sulfate work chemically, work biologically with the bone compared to other grafts. Normally, when we're speaking about other grafts, we are talking about osseointegration. We are looking for having osseointegration with the graft. And then, actually, the bone is still just a small, tiny void between those granules. And if the graft is in a good quality, each particle will integrate with the bone. So we are talking about functional continuity between those particles, and the overall mass is some kind of repair in the area. Calcium sulfate is work completely different. Actually, the only time that it comes in contact in integration with the bone is when you place it. Immediately start a degradation process. During this degradation, there is a release of tons of calcium, ions of the calcium. And those start to precipitate in the form of HA and calcium phosphate of the bone. Then, of course, come the osteoblast, start to secrete the collagen, and vice versa. So actually, there is never a direct contact between calcium sulfate and the bone during the healing. Therefore, it's called a bioactive material. It's not osteoinductive material because you don't have growth factors that will give signals to the pluripotential stem cell to become an osteoblast. But actually, it's a bioactive because it's a very favorable environment to the bone to be built in that way.
Yeah, so it doesn't actually...
I hope that I was clear.
Yeah, it doesn't actually turn into bone. It just creates a favorable environment for bone to grow, whereas most other bone grafts actually fuse with the bone and turn into bone.
Exactly.
So getting back to the 3D bond, after placement and some sort of coverage, it gets covered for 10 days, and then you allow that place to that socket to heal. How long before re-entering that socket for implant placement should clinicians typically wait? Is this 4 months or 6 months? What's a typical time that you think bone turnover and implant placement in a socket could be?
Since the graft does not interfere with the healing and does not disturb the healing, and it's simultaneously replaced into the patient's own bone, it's exactly the time that is needed when we make an extraction and we don't do nothing. Normally, 3 months is enough. We will have enough vital bone. And what surprisingly is that the cortical plate with the time will build again because most of the area is the patient's own bone, vital bone. So 3 months is enough in most of the cases. Just in very, very large cases, when we use a composite graft, sometimes we need 4 months. But most of the cases, 3 months are enough.
Now let's go back to the other product. We talked about, one of the main products. You have the 3D bond. Why don't you tell me about your other product that is made for more extensive grafting? And that one is the Bond Apatite.
Exactly.
Tell me about the Bond Apatite and maybe what its clinical indications are and how to go about placing and using that.
First, we started with the 3D bond. Actually, the 3D bond was not in that name. It was, and up until now, it's under the name BondBone. BondBone actually and 3D bond are the same product, but they have a different brand name because BondBone we are we are manufactured for MIS company, and they sell it under BondBone. And the 3D bond is the same product under Augma brand name. So actually, it's the same product. So we started with that. It's a great product, but you need to know how to work with it. So In a larger defect, we recommended at that time that the clinician will make the cocktail, the mixture by himself. So you should take about 1 cc of 3D bond, and take your granules half cc. It needs to be half cc and not half gram because it's different. And then the clinician needs to mix it by itself. And of course, there was a lot of mistakes that can be done by the quantity of liquid, by absorption of liquid, by the mixing, by all of those stuff. So the learning curve was much longer. So we decided to develop something that will be much easier for the doctors, that they will not need to mix by themselves. So we created the Bond Apatite, and in the engineering of this product, we insisted that as quick as possible, maximum amount of vital bond will be built in the area, and still we can preserve the cementing properties of the material. Later on, we developed as well a unique syringe. I'm sure that you saw it in our video, in the hands-on video, Bond Apatite hands-on video. You can see it on YouTube. We developed a unique syringe that actually contains as well the liquid inside. So the only thing that the clinician needs to do is to push the shaft. The liquid is coming inside. The surplus of the liquid will go outside. And then you will have the exactly right viscosity, because as you know, it depends as well on the viscosity that you can have in order to have the best quality of the cement. So this syringe actually avoids any mistake that can be done, or almost any mistake that can be done, by untrained or improperly trained clinician. And then the only thing that the doctor needs to do is to eject into the side the material, press it for 3 seconds, and close the flap. Of course, we need to remember that when we work with cement, there is a working time. It's not like granules that there is no working time and you can work with them 1 or 2 hours and nothing happens. Here, the overall working time is about 3 minutes, but you don't need more than this, because in less than a minute, you can finish the entire graft placement and stabilization. Eject it into the side, press for 3 seconds, and close the flap. It's very important to prepare, of course, the soft tissues and all the defects before you start activating the material. So actually, you start activating the material just after, when everything is prepared. You prepare the soft tissue, you prepare the hard tissue, then you eject the material and press for 3 seconds. Don't press more than this. What we saw that some clinicians, difficult for them to understand that it's so easy as it looks. So after that they place it, they start to play with it. There is no need to play. You eject it, you press, and you close. Another thing that is important, normally when we work with granules, we need to have the soft tissue tension-free. Here we can have it with a little bit tension, nothing will happen. Even if the soft tissue will be open in 1 or 2 millimeters, nothing will happen. Actually, it will be closed after 1 week, the soft tissue will be closed. So we don't release it too much. The advantage that we are not connected the flap to the muscle, because if the muscle will move, it will move all of the flap. So we cut it until we think that it will be sufficient for us. Even if there will be a little bit pressure or tension on the flap, nothing will happen, because it's coming direct with the graft, and there is no membrane in between them.
Okay, so because there's not a membrane that typically needs to be used, you're saying slight tension on the flap and or slight opening of the closure is permitted. It's not maybe desirable, but it is permitted at times.
Exactly. Because what is important, because we don't use a membrane here, it's important that the flap will not be flappy. It can be flappy because if we release it too much, we come in contact with the muscle, so every movement will move the flap a lot. So we release it until we feel that it will be sufficient to close. Even with a little bit tension, nothing will happen. And of course, something which is very, very, very important, if we have a vertical cut, they must be far away from the defect, at least 1 piece, mesial or distal, not very close to the defect, because if we cut the flap, the vertical cut, near the defect, there will be a sloughing of the soft tissue into the defect due to the replacement of the graft. So we need to be far away.
So moving the flap away from the defect is important with this procedure.
Exactly.
Probably in any procedure, but more specifically for this, you need to have
Of course.
Yeah.
Of course. Surgery must be respected, no matter what we're doing.
Yes.
So this is important.
So let's walk through an example where someone would want to use this. Maybe like a lateral augmentation would be something someone would want to use this for. You're saying that they can decorticate the plate, place the material, press for 3 seconds, close the flap. There's no membrane needed, and even primary closure isn't an absolute. Is that correct?
Primary closure is very important. 1 or 2 millimeters, it's still within the borders. 1 or 2 millimeters, it's okay. One thing is very important, that the release of the flap will not be too much, because you don't have a membrane, any movement can move the graft during its replacement. So a little bit tension, it's very good, it's okay, there is no problem. 1 or 2 millimeters, it's also okay, but a good suturing, of course, we must. Now, if we have a big lateral augmentation, I would recommend to use what we call a partial thickness horizontal mattress suture. Partial thickness, actually, it means that you go into the connective tissue, but you don't go outside into the epithelial part of the soft tissue. Just in the middle, like when you have a jacket, you don't go to the other side, just in the inner side, okay? And then you make your horizontal mattress, and of course, later on, any other suture is fine, just to close the flap.
Excellent. Okay.
And this is very easy. So actually, we can finish lateral augmentation, which normally takes us about 20 minutes, 25 minutes, in less than a minute. And it must be simple, as I say. Place, press, and close. PPC.
You're not needing, tinting screws or any mesh membranes with this. Just press, place, and close.
For lateral augmentation, there is no need. Vertical augmentation is a completely different issue. Vertical augmentation, the material can be very elusive, because when you place it, you can do almost everything with it. So you can have that feeling that you can place it vertically and then you will have bone. No, you will not, because during the replacement, there will be lateral movement that will prevent the bone to be formed there. That bone to be formed need to have two essential requirements. First, it's space maintaining, and second is graft stability. No matter what kind of graft you are using, if you don't respect those two rules, probably you will not have bone in that area. So if you respect the space maintaining and graft stability, you will have a good result. So in vertical augmentation, you must protect it with a rigid barrier, with a rigid barrier that will prevent the lateral movement of the graft during the healing. In a lateral augmentation, you have the bony wall. So in lateral augmentation, the essence, fenestration, and all of those cases, the only thing that you need to do, place the material a little bit overfilled, about 10% overfilled than what you need in order to compensate for shrinkage during the healing, and close your flap.
Okay, great. And you get 1 cc of bone per syringe. Is that correct?
In the 3D bone, we have two forms. We have 2 syringes of 0.5 cc in one box. This is for the 3D bone, or 2 syringes of 1 cc in one box. The Bond Apatite is just one box and 1 syringe, which contain 1 cc of Bond Apatite.
Gotcha. You've got quite a resource of information and videos available on www.augmabio.com. That's AUGMABIO.com. So that's for your Augma biomaterials.
That's right. There the clinician can find almost any information that he would like to know about the product. As well, he's always welcome to contact us for any question, for any clinical question. There are many clinicians that when they start to work with the material, they send us some of their CT scan or some of their radiography, and they consult with us. Is it proper for this use or is it proper for that use? And we're doing our best in order to train them in a proper way, because this is a different concept. We need to think differently. It's not granules. It's much more easy, but still there is a learning curve. Short one, that exists. And we do everything in order to educate and to teach doctors to do it in the right way, that they will have the most predictable and better result that they can ever have.
Sure, that's great. Now, I know, I'm in the United States, so if I order is this going to be coming from the U.S. or what can I expect with shipping into the United States, or is there a distributor in the U.S. or how do I buy it? Do I only buy it through your website?
No, actually, you can buy directly from our office, which is located in New Jersey, or you can even order it for our website, and we will ship it to you from our office in New Jersey to any place in the U.S.
Okay, great. And then you've got maybe other distributors worldwide, is that right?
Yes, we are selling this actually we have, as I said, we are a manufacturer under private label also for an MIS company, and they sell it in about, I think, 60 countries or something like that. But we sell it under Augma brand in Germany, in South Africa, France, Sweden, Switzerland, and some other countries. And of course, Israel, which is our headquarters.
Is there anything else that you would like to emphasize that maybe I haven't asked about your product, or about any sort of training, or about any of your products that you would want people to know?
I think the most important is that first, this is our commitment to train. Everybody that has some question is always welcome to share his question with us. We will do all of our best in order to provide him the most suitable support. The other thing is we need to understand a different concept. There is a learning curve, short but exists. So we are here to support the clinician for their first steps with the product. But once they will get used to the product, it will be very difficult to go back, because it changed dramatically the way that we perform augmentation procedure. And I'm happy that we can provide it to the clinicians. And still, the price is reasonable. It's not something, that it's unfeasible for most of our clients, most of our patients. It's a very reasonable price, and even if you make the calculation, if it saves you time, it saves you membrane, and it gives you a better bone, so in the end of the day, the price is very, very attractive.
Great. Yeah, no, I think that's what people are looking for, is something that is easily introduced into their practice. So it's got to be cost available, and then it's got to be, create advantages over other products. So you're saying, there may be instances where maybe people could, not use a membrane, so that's saving cost. And there's other advantages where it might increase predictability because it's, it's much more stable than loose bone. So it might even make some of these grafts more predictable than what clinicians were doing previously.
Mm-hmm.
Yeah.
Mm-hmm.
Well, that's great. I really look forward to, starting to integrate this with my practice. I do a lot of grafting, and most of it's either with taking teeth out or trying to solve defects. And it looks like these products, would definitely be able to help me in setting up a lot of these implant cases. So the best way for people to do this is just get on your website, augmabio.com, order some of your materials, and get going. Is that right?
Yes. And by the way, we provide the clinician as well, free of charge. Those who buy the product, we provide them as well a training kit. We provide them the way that they can use it on a model, feel it before they use it on the oral environment, because it's different than what they are used. And always we are open for any question. And what we saw is one thing: those who pass the learning curve just love it. And of course, as with everything, there are those who are afraid to try something new. Maybe they didn't follow the instruction and they didn't feel comfortable with the material. But those who know how to work with it, they are with us, and they are very loyal customers to us. So we are here in order to support all the time. Yeah,
that's great. I think you've got to stand behind your product, but then you've also got to help clinicians integrate it, because if this is something new and somebody doesn't know how to use it, they may be fearful to integrate it into their practice. And so if you can help get people over that learning curve, it sounds like people are really going to love this product and love the way that it handles.
That's right.
Yeah,
that's exactly.
Dr. Amos, I really appreciate your time talking with me about your product, and I look forward, like I said, to get this integrated in my practice, and hope others are willing to do so as well. So I will direct people to augmabio.com, and look forward to getting some cases of mine posted up with some of your material.
Thank you very much for your time, and thank you very much for the interview.